It's another Thursday evening. Welcome to State of Affairs. I'm Francis Aben. Tonight, we turn our focus on a very, very important matter. It's about Ghana's healthcare system, not the infrastructure per se, but the access and the ability for many to access it from the point of funds and also to even the ability to get the quality care required. My guest tonight is the Chief Executive Officer of the National Health Insurance Authority, Dr. Lydia Selby. She's been kind enough to join us this evening for our conversations for a body that was created some 18 years ago and how things have looked since she has been at the helm and what more we can do going forward. Doc, good evening to you. Thank you for coming.
Good evening and thank you for having me.
Okay, so I guess we can begin with a quick check on how things are looking now, because the last 18 months has been uncharted waters for Ghana, with COVID-19 bringing healthcare really under a stress test. How would you describe our healthcare system today, from your point of view as the head of the NHIA?
Okay. Well, for Ghana, we decided to handle COVID as a public health emergency. Therefore, it didn't come under the National Health Insurance Scheme. We haven't reached the critical mass of membership that would allow us to do that.
Okay.
So government took it upon itself to manage it centrally. However, what has tested a lot of countries is the other healthcare needs while COVID is raging. And with Ghana, because we now have the mobile authentication for every visit, we were tracking it. And COVID came to Ghana in March. We usually have about 3.2 million visits a month. For April, we had 1.9. That means more than 1.1 million visits didn't occur. And it didn't recover till last year, December. And we've been hovering around 2.93 million visits from December till now.
Yes.
Now, that means 1.1 million visits didn't occur. And it makes you wonder, who are they? Are they the hypertensives and diabetics who, because they don't have overt symptoms, decided, listen, I'll manage myself at home? What problems are we storing for ourselves for the future?
Yes.
So that's something we really have to analyze and see the effect, the long-term effect. But I think on the whole, Ghana has managed the COVID very well. And I think the international community has acknowledged the leadership of the President and our Minister of Health in the management.
For the work done so far. Yeah. Okay. Now, much as COVID has had its own strain on how things have been, and the numbers you mentioned for the visits per month are quite staggering, 3 million. So if 1.1 have been staying home and not coming, and you can understand why, the risk of getting it and, you know, the tough issues that come with it. But beyond that, as an authority, has this period given you more to worry about, to think about how to manage your role in our healthcare system?
Yeah. Obviously, we've realized that we've used the opportunity to do a lot of communication and education. Because we realize that even the providers don't really understand the benefit package, which is the diseases we cover, the operations we cover, investigations we cover. So we're doing we've used the kind of COVID time to do a lot of webinars and virtual education. Last year should have been the year of the member, where we were really going to reach out. And COVID has put a break on that.
Okay.
But it's something I think we realize we have to do a lot more of. If you don't know what you are due with your membership, when you get to a facility and you're not getting the due, you can't say anything because you don't actually know what should be given. So it's something we're working on. And we've also used the opportunity to work together with the providers on the quality of the care given. There's no point in everybody having access if the quality is poor. So there's a quality team set up, which involves us and all the other agencies under the ministry. Most countries use their social health insurance program to drive quality improvement because you're the payer.
Yeah.
And if the quality comes with a financial penalty, it changes the landscape. Since the health insurance came, I think there have been remarkable quality improvements, but we can't rest on our laurels, and there's still some way to go.
There's some more work to be done. You said something about the workshops and training that was happening. For a country of almost 30 million, how many were able to join these webinars to get what you were trying to communicate?
You'd be surprised, because everybody does Facebook and all those things. So you'd be surprised how many people are online in Ghana. But the training and communications have been with our providers.
Okay.
And they are all people who are online. We have to be innovative about the public, what we can do with the public going forward.
Okay. I guess we can now look to how things are for the NHIA, or let's say the scheme first.
The scheme.
How would you describe its health? And I ask the health because often when talk of the scheme comes up, the first question that comes up is arrears for those who are providing the service at the facilities, how far we've done with those payments, how are we sustaining the scheme for all these years? How are things looking from that perspective?
The scheme is sustainable. It is financially sustainable. We have recently done an actuarial model, and thanks to our development partners, an ILO fellow came this year to update it based on COVID data, COVID financial data of the country. And yes, we are still sustainable up to 2035, which is how long the model goes. It obviously depends on the decisions we take as a country. If tomorrow we decide to put every disease and every medicine in the world on the scheme, it will collapse. It's about using evidence to do what the country needs, what will impact the greatest number of people, and do it in a stepwise fashion. We've built almost 200 scenarios. When you add this, when you take out that, and I tell you, 75% of those scenarios, we can have a surplus of 1 billion cedis by 2030.
You're joking.
But there are riders.
Oh, but you get me excited and then you say but.
There are riders. Obviously, there are some key points. Our scheme depends on our GDP. As our GDP rises, the scheme has more money. It depends on the releases. Much as it's earmarked funds, releases are dependent on kind of the macroeconomic position of the country. One of the third riders is the cost of medicines. The cost of medicines in Ghana rises faster than the normal inflation.
Why?
There are a lot of supply chain challenges. If we don't control that, it puts extra pressure on the scheme. We have to maintain it as close to the normal inflation of the country as possible. Medical inflation tends to be higher than normal inflation for most countries. So that's something we have to look at.
Is it artificial or it's a natural consequence?
A lot of things. You know, health is very emotive. And once you have a health problem, you are literally willing to pay anything. Supply and demand, the prices go up. So it's a challenge, and it's not only Ghana that is facing that.
So there are some that hijack our emotions to sell things for us.
Exactly.
Wow. And how well are we done in dealing with that?
Well, the ministry over the last 3 or 4 years has introduced what we call framework contracting, so that the most essential medicines that the bulk of Ghanaians need, we try to negotiate a price with the manufacturers and distributors. It's not an easy thing to do. The first couple of years were a little tricky. When we're getting a handle on it, then COVID came with its supply chain challenges. So, but I must say, I think there's good faith on all sides to get this done for the good of the country.
Okay,
so,
that's on the medical supply. Okay, but for the financing module, just to state it for a moment, what I've been made to understand is that a good chunk of the financing is from the levy. the National Health Insurance Levy, then only 4.5% are from premium payments. After 18 years, should that percentage not rise?
Nope. Remember, ours is a hybrid scheme. So it's a combination of tax, what I call payroll deductions, and premiums. Being a low to middle income country, the premiums are not the driver of the health insurance scheme. And that's what it should be if you want equity. So our premiums are not actuarially determined. It's really a token to give the public a feeling of ownership of the scheme. If we were to make it completely free, I don't think people would value and they may abuse it. But this token is to let you feel that this is there to support me. I paid something, I own it, I must make sure it succeeds. So 60% of our money comes from the levy, about 25% or so comes from the SNCC contributions. And that's what it should be, really, looking at global practice. Since we introduced the mobile renewal, the informal sector adults, who are the ones who pay premium, their percentage has increased. So now we're looking 8%, 9% of our income is coming from premiums and processing fees. And as more and more people find it easier to renew themselves, that percentage will rise.
Will also rise. But if on the bit on the levy, the National Health Insurance Levy, per the quantum that we're paying, is it enough? Or should we be looking to pay more?
No, it's enough. It's 2.5%. And another 1% was added recently, but that is towards COVID. It's enough. It's enough per our actuarial model. As I said, we updated it just 2 months ago with the latest data from finance on the expected GDP rise and therefore the expected levy. And we are still sustainable. Okay.
And for this levy, of course, it's tailored directly towards health insurance. But for whatever comes in that kitty, do you get everything that comes?
As I said, it depends on the macroeconomic situation of the country.
But we're paying. If everybody's paying, and
other priorities at the time.
Okay.
But we keep a strict tally. There's nothing that is kind of lost. We keep a very strict tally. We know exactly what is due us.
So you know exactly how much we pay and how much you get, and the tallies.
Well, no, what I mean is we know how much has been collected.
Okay.
If you don't give it today, you will give it tomorrow or next week.
Okay.
So that we're keeping strict records. And I recommend the Ministry of Finance and Controller. They sit with my team every quarter and we do a reconciliation and they sign that this is whatever is still owed. And last year was very good. We got a lot of the arrears dating from way back. So they
How much did you get in? I'm curious. How much did you get last year?
Probably around 1.9 billion.
CDs?
Yeah.
Okay. Ordinarily, how much were you getting on average per year?
How much was being released?
Yes.
1.4, 1.5.
So it went up somewhat.
Yeah.
Last year.
Yes.
I see.
Very much so.
I see.
You haven't heard any providers complaining because we're really rapidly catching up with that.
With the arrears payment.
Yes, but what we need to talk about is, you see.
Okay. Well, you let us finish on this and then we'll go back. So still staying on the cash. That quantum has come in and that's great. But in terms of how we keep track and improve, okay, maybe I just have to look at this once again. So in terms of monies that are coming in, it's increased somewhat. How do we get more to make it better? And I ask this question because your predecessor, I recall, I spoke to just before he exited. And at the time, he was talking about how we should look to refinance the National Health Insurance Scheme. There was a matter of syntax that came up. It's fizzled out. I've heard little to nothing about it. Is it that model? We should leave it? It's fine? We're good?
What I would like to say, we got our actuaries to look at some of these syntaxes. Either we don't sin, or we don't sin officially.
What does that mean?
If you want to tax smoking,
Yes.
and people don't smoke officially, what are you taxing?
But they're buying the smokes.
That's why I said officially.
Yes.
So it's unofficial buying of smokes. Therefore, it's not taxed. If you get my drift.
Yes, I get you.
And that is what, looking at some of the various syntaxes, it seems to be under the table sins. Therefore, the tax we would get is not enough to make a difference. Some countries are taxing sugar. That is a hard sell.
Why?
Because it puts the price of sugar up. And your populace, in this COVID pandemic, the populace will turn against you. So, for now, the actuarial model looks good. It's a new one. It looks very good. Let us run with it for a while before we think of adding more burdens on anybody. But I think the important thing is the flow of the funds through the system.
Okay.
Is what is important.
So for the providers, how many months in arrears do you owe them?
This is where we need to explain. We agreed that on submission, we would pay within 3 months. We have challenges with submission as well. I went into the system. Most people are now submitting June.
June. Okay, and I'll hold you on that thought for now. We'll go for a short break now. You're watching State of Affairs here on GHOne Television. I'm Francis Aban. My guest tonight is the Chief Executive Officer of the National Insurance Authority, Dr. Lydia Selby. After the break, I'll let him finish on that point on the payments and the issues therein between the NHIA and the service providers. Stay with us.
Pack up your day with your favorite packed milk and choco biscuit, now in exciting new packaging.
You gotta have a smile.
Only the packaging has changed. The taste remains the same, crispy and delicious.
Love the way it tastes. Feel the perky buzz from your toes to your face.
Pack up your day with packed biscuits in exciting new packs with the same great taste. This advert is FDA approved.
When we connect, everything is possible. Whatever seems unreachable becomes even closer. Building partnerships. Redefining the norms. Because when we connect, being there becomes possible. And new ideas come to life. Stay ahead and stay connected with MTN Business Broadband. Superior internet solutions that drive your dreams. Sign up today on broadband.mtn.com.gh or call or WhatsApp 0244 308 111.
For many years of serving the world with herbal and alternative medicine, a combination of homeopathy, naturopathy, reflexology, and many more, we've been successful in treating many complicated conditions. We deliver excellent and effective services to people from all walks of life through scientific and traditional means using electronic pulse machine, serogen bed, circulation devices, physiotherapy, massage, and many others. We have a well well-equipped laboratory with advanced diagnostic and treatment devices to help detect your illness, so we know the right medications to be given.
I had a serious cough for 7 times. I sent my inspect to South Africa for tests. Nothing was found. I came to Dr. Amin. Within 5 days, I was healed.
Our zeal and passion to save lives and outstanding years of achievement have won several awards like the American Black History Honors, Master Practitioner of the Decade, amongst others. This is why we say, go Herbal, go Amen. Amen Scientific Herbal and Alternative Medical Hospital. Allahu Shafi, God is the healer.
Don't stop thinking about tomorrow. Don't stop, it'll soon be here.
I have a song I'd love to share with you today. Come on and sing along.
Look what I'm doing, do it just like me. Look what I'm doing, spin around with me. Look what I'm doing. Look what I'm doing, come and brush with me. Come and brush with me.
Alomo bitters. If you do me no chini, that's so you're authentic.
And you ain't tribute.
Alomo ya, mproma yenji yemie. Medi akimpa kwesha alomo ya, chami alomo na usisenkra. Ya konu say ya, ya no say ya, ya konu say ya, ya konu say ya, ya konu say ya. Alomo ya, mproma yenji yemie.
Alomo Bitters, 20 years, the Camry Pakroji. No Nyansem, one Toma Nipa winning Fidu watch and Sessa Pimfonum. FDR, if you say Jadian Craft will more Jatum say, yeah.
Alomo, authentically African.
But you also feel a color bay, a blue and that's a white. In a blue. I see blue. But if you blue, I saw a sugar crab. But your blue house, we are minty. Let's say you are damn blue biao. Not just cross them. I want you to go back your food now. Yeah, I'm here to be found. Who feel now so much wrong? Where blue was blue color na pa I white. Where they say fanya wayo. Na say na me book am be painti fie nyina. What painti that way? Painti fie. Oh no su faka down for paint. Ama o fie na dan chameleon house. E change color every season. Enunti na Ghana for. I Ghana for Ghana for paint. Agatex paint. Agatex paint papa. Say you blue you blue. Kakra bi na o here. No na come on. The boss is so cost and the Agatex you pass do engagement now. Let's move back. Mama Agatex. I can see me. We dey move for bro your wife. Oh, as well yes sir.
Thanks for staying with us. You're watching State of Affairs here on GHOne Television. I'm Francis Aben. My guest tonight is the Chief Executive Officer for the National Health Insurance Authority, Dr. Lydia Selby. Before the break, we were talking about the payments for the service providers by the NHIA and what the issues have been. You said the arrears are now how many months?
Well, currently, most of them are submitting for patients they saw in June 2021. And we have just started paying March. So we've paid the bulk of February and we've started paying March. So it's about 3 months.
Okay. Yeah. About 3 months?
Yeah.
Okay. Ordinarily, is that what it should be, 3 months?
That's what was agreed, that on submission, we should pay you within 90 days.
We've run this particular payment system for quite a while now. Is it foolproof? Do we get value for what they claim they've offered as a service and what you should pay?
Well, with time, it's not foolproof, and it never is. No country can say it is. But I think with time, we've been able to weed out quite a lot. And I'm appealing to all of you. We now have a system where when you visit the facility, they do an authentication, which hits our database. We send you a text message to say, such and such a clinic on this day at this time says you are there. If you are not there, just press 2 on your phone. You don't have to call, send us WhatsApp. Just press the number 2.
And send.
And it will come to us. And we can then track it back. So we have some mechanisms in place to reduce fraud and wastage. I think the biggest challenge we have now is the co-payments, illegal payments, under-the-table payments, whatever you want to call it.
What are those?
You know, the whole point of UHC and having a social insurance scheme is not paying at the point of service. That is key to UHC. Whatever payments have been done ahead of time through your premiums or whatever, at the point you need it, you should not be asked for money. And each time that happens, we have failed the people of Ghana.
But that happens often.
It is now happening quite a lot, and it's something we are determined to stamp out.
What is causing that? Because every time there's a threat of cash and carry, the refrain you hear is monies have not been paid, so they have to find a way around it.
Well, at the moment, monies are being paid. We have done a costing, recosted the services. A few will go up. Some will stay the same. Some are supposed to go down, but the providers won't agree, so we'll keep them the same. We are not so out of place that money should be demanded. And I think we need to now clamp down. Enough is enough.
How are you going to clamp down?
Well, we actually have mystery shoppers in facilities at the moment who are taking the evidence, and we will deal with those we need to deal with. I'm going to give you an example. Insulin comes into this country at $3 a vial. That is, let's say, 18 cedis. NHIA reimburses 42 cedis a vial. You cannot tell me that all of this is taxes or there's something very wrong.
Wait, 18 cedis to 42 cedis.
We reimburse at 42 cedis.
Why?
Because that is the price we agreed with the manufacturers. With the hospitals and clinics. Yet still, patients are asked to top up. That, for me, is a challenge. We have given you all the markups, add the taxes, add the markups. I'm particularly pained about the insulin because it is such an important drug.
Diabetics.
And we have had discussions with some of the manufacturers. What is the problem? That from $3, we reimburse at 42 cedis, and a patient is still asked to top up. There's something wrong with our system. And these are some of the areas we need to address. The ministry has now set up a task force, and we will deal with this because it is the one thing that is destroying us where UHC is concerned.
Okay, so this demands for cash beyond what the scheme covers. I'm sure there are many who are watching us tonight who can share varied experiences on this. So is there a reporting mechanism when it happens? What are the options for people?
Insist on a receipt. Insist on a receipt because that is the evidence they've taken the money. And bring it to us. We have a call center. The short code is 6447. It's 05444 6447.
Okay.
That is our call center. They will respond to you in 7 different languages and tell them what has happened, and then we'll they will pass it on to our field agents to follow up.
Okay, let's take a moment to talk about what the scheme actually covers, because a lot of the time I've had people who come back from the hospital and say, I went with my card, I was made to pay for things that they thought that they should not be paying for. So help us with some education tonight. For someone who's holding the NHIS card, who goes to the hospital for care, what does it cover? What does it not cover?
It covers outpatients, inpatients, certain surgeries, investigations, medicines, whatever. We have actually checked it up. There are 429 operations and diagnoses that it covers. 191 investigations that it covers. We have 532 formulations on our medicines list that it covers. There are some that are never even used, but when we're talking to the experts, they figured there are illnesses in Ghana that may need this. So when they say it doesn't cover, it actually hurts a lot, and we need to educate the public a lot more so that they can stand up for their rights. Some of the challenges we have is if you are a patient and you walk to a tertiary facility without being referred, they will take money from you, because you shouldn't do that. You should go to a clinic, a health center, a CHIPS compound, and let them assess you. If you need specialist care, they'll refer you. So we all need to know how to handle ourselves.
But you see, the truth also is that a lot of people don't know where they go to when they have certain conditions for care. Thus, many go to what they know.
Exactly.
For instance, here in Accra, somebody's feeling unwell, feverish. First thing they'll rush them to either Rage or Kolibu.
Shouldn't be, unless it's an emergency. You really should. There are enough facilities in Accra, Kumasi, Takoradi. Now, thanks to the health insurance, there are clinics virtually everywhere in Ghana. We have 4,444 credentialed facilities that take NHIS cards across the country. So you really need to go to a lower level facility to be assessed. And then, if you need, they'll refer you. My colleague at Ghana Health Service, Dr. Patrick Kumabwaji, he's setting up these network of practices so that when you go to the first one, they alert those higher up so that it's a whole network of practice to make sure you get the best possible care without you having to rush to the top. And we think that will, to give you a continuum of quality care. As you are being cared for, somebody is supervising from the top. You don't have to go too far from your home. And that is the way to go. I would advise everybody to find a primary health care provider. That is a health center, clinic, primary hospital, CHIPS compound that knows you well, and go there all the time. Health is about changes. When they see the change, they know they need to intervene. If it's beyond them, they will seek advice or send you to the next level. That is the best way to get quality care. But just jumping to reach to a doctor or nurse who's never seen you in their lives, you even put that person under pressure, that healthcare provider, to make a judgment call on the spur of the moment. If you go to your regular clinic, whatever you tell them, they add to what they know about you. That gives a complete picture, and they are better able to help you.
Okay. Now, I'm sure you've heard this before. Complaints about people who go with the NHIS card.
And they don't get.
And the kind of care they get is markedly different from somebody who's on either a private health insurance scheme or is paying cash down. How do you vet and assess the quality of care persons holding NHIS cards get at our healthcare facilities?
In terms of medical care, I mean, on the technical side, it's probably not that different. But attitude, yes. I think there's an issue around staff attitude sometimes when you have a health insurance card. Part of it is because we advertised health insurance as a pro-poor scheme. And I think there's a fake belief or perception that if you have a health insurance card, it's because you're poor. And that should not be so. It's something we all have to work with to change it. But I think also, even at the provider level, some of them don't understand how much is actually covered. So we're doing a series of webinars with the health providers, but you hear things like, I have to pay for the folder, 5 CDs. For what we pay for OPD, if that folder costs 5 CDs, you're going to use it for another 40, 50 visits. Why should you pay 5 CDs each time for your folder to be brought? When you think about it, it's kind of daylight robbery. And it's something that needs to be looked at.
So when you have conversations with Dr. Patrick Umabuaji, who a lot of these facilities are under his ambit, what does he tell you about how these things are being dealt with?
No, he is now. That's why I say we have a joint task force and we're working on it.
So if anybody goes and gets this kind of quote-unquote discriminatory treatment because he's holding the NHIS card, there's a means to address it?
There's a means to. You can call our call center. That's what I said. We will respond to you 7 different languages.
And the complaints are dealt with speedily?
Yes, and we are, now we are working together and supervised by the ministry. So things are getting better.
Okay.
But we have a way to go.
Okay. Let's talk a bit now about the benefits payments. How's it looking now?
Well, as I said, we are paying much. So we are on track. This year, we have paid 678 million to providers so far this year for claims. The public has had the largest share, public facilities, 51%, private, 28%. The privates have had about 195 million, the mission about 128 million. And the public's 347 million. This is valuable injections of cash into the health sector. We also pay part of the public health expenditure of the Ministry of Health. So vaccines, polio, measles, and all that comes out of the fund as well. Anti-snake serum, some tuberculosis drugs, some mental health drugs, some HIV testing kits. So there's a public health component, 10% of what we get goes into all that. And then the rest goes to pay claims.
Okay. I'm sure you've also heard this before about and educate me, because I'm sure many are watching tonight and will need clarity. When you go to a facility for care and you're giving a prescription and you go with your card to go get the medicine, does the scheme have a certain grade or quality of medication that is given?
Every medicine in the country should be FDA approved and of equal quality.
Sure.
Now, the law says we should write or we should deal with generic names. You cannot promote a particular brand. So when we write amoxicillin and clavulanic acid, the one most people know is amoxiclav. You can't write amoxiclav. You have to write, because that belongs to a particular company. So you write amoxicillin and clavulanic acid, which is the generic name.
Yeah.
Now the hospital or the pharmacy can give you any company's brand of that particular drug.
But you hear the nurses and doctors also tell you that this quality is best for your patient. And that go for that one.
If they feel the drug is not a good enough quality to be given to patients,
is that what it is?
They should refer to FDA and let FDA take that particular brand off the market. Once it's been FDA approved, it should be of equal standard. people like innovator brands. Maybe some people like Ferraris and some people like Toyotas. It still gets you from A to B.
But it's about care and the speed with which the medication will work, isn't it?
It shouldn't be. Once it's FDA approved, it should have the standard ingredients.
Yes, ingredients, that's true. But Dr. Selby,
yeah,
I'm sure you will also agree with me that some medications work quicker than others. Even if it's the same amoxiclav.
It depends on the dose.
As an example.
No, I think it depends on the dose. I rarely buy branded medicines.
Why?
Because I think if somebody is going to fake a drug, they are likely to fake the branded one than the generic one.
Oh.
So I tend to buy generics. But that's a personal thing.
Okay.
Yeah, there are substandard drugs on the market. And maybe the doctors and nurses know which ones are not at par. But we would be doing the country a great deal of good by reporting to the FDA to have those drugs taken off the market, rather than play these games. There are some components of, some people believe that it's not the active ingredient, but other ingredients that go to make up the drug that some of their patients don't react well to. That's why they advise them to go for innovator brands. I'm not an expert enough to know, but I remember when I was practicing in the UK, this was a challenge because the drug company would take us out for dinners. And you go to the next day and you prescribe the brand of the company that took you out to dinner. That's what happens all the time.
Same applies here in Ghana?
I don't know, because nobody has really, I don't practice anymore here. So I can't really tell what happens. But in the UK, it was a problem. It still is. In the US, it's a problem. And for a low middle income country, I don't think we need to go the innovator way. That being said, we do have a few branded drugs on our list just because the generic version is not yet out.
There's a part 2 to this that we will look at. You're watching State of Affairs here on GHOne Television. I'm Francis Aben. My guest tonight is Dr. Lydia Selby, the Chief Executive Officer of the National Health Insurance Authority. After the break, we'll look at another part to do with the medicine list, and then look to how what we're doing in collectively helping to make the scheme better than it is today.
It's an exciting time to join Surfline. We've changed our prices in your favor with bigger and better bundles. Also, if you decide to get a new device, we give you 50 gigabytes free data.
Alomobites. In fear do me no chini. That's so authentic.
Anio. Any entry.
Alomo. Ya. Mbrama yenji yenie. Media kimpa kwesha alomo. Alomo ya. Chami alomo na usisengura. Ya kodi say ya. Ya no say ya. Ya kodi say ya. Ya kodi say ya. Ya kodi say ya. Alomo ya. Mbrama yenji yenie.
Alomo Bitters, 20 years, the Camry Pakroji. Nunu Nyansem, one Toma Nipa winning Fidu watch and Sessa Pimfonum. FDR, you should say Jedian Crat to Imagiatum say, yeah.
Alomo, authentically African.
Yellow!
we have a very big surprise for all of you. You get a sonata. You get a sonata. You get a sonata. What's the opening a sonata if you want it? You get a sonata. Sonata. You get a sonata. You get a sonata. And you can get a sonata too.
Everyone's excited about the MTN Act 25 promo. Just keep using your MTN number and talk, text, browse, and more to gain points, and you could win one of 25 Hyundai Sonata vehicles and cash prizes each month in the MTN Act 25 promo. Dial *156# today and begin your journey to win big.
Hey, man, try.
Only on MTN, everywhere you go. Terms and conditions apply.
I have a song I'd love to share with you today. Come on and sing along.
Look what I'm doing, do it just like me. Look what I'm doing, spin around with me. Look what I'm doing. Look what I'm doing, come and brush with me. Come and brush with me.
Pack up your day with your favorite packed milk and choco biscuit, now in exciting new packaging.
You gotta have a smile.
Only the packaging has changed. The taste remains the same, crispy and delicious.
Love the way it tastes. Feel the perky vibes from your toes to your face.
Pack up your day with Peg Biscuits in exciting new packs with the same great taste. This advert is FDA approved.
Thanks for staying with us. You're watching State of Affairs here on GH1 television. I am Francis Aban. Tonight we're discussing Ghana's healthcare system, from access and the matter of cost as well, and all the issues therein from the health insurance perspective. My guest tonight, Dr. Lydia Selby, the Chief Executive Officer of the National Health Insurance Authority. So, Doc, before the break, I was talking about the other side to the medicine issues. Not only do we get complaints or concerns coming up from nurse to prescription, but even at the pharmacies, and I'm sure you've heard those accounts as well. How are you addressing this?
Right. Not all pharmacies are signed up with the National Health Insurance Scheme. So if you go to a pharmacy that is not signed up with us, they will take cash from you. You need to go to one of the credentialed pharmacists.
So do all pharmacies in public hospitals take NHIS card?
They have to.
They must.
Don't? Kolubu is a peculiar example.
Why?
We're working on them.
No, I need clarity on that because a lot of people go there and they're stunned by it. What's the problem there?
Kolubu, the main hospital still will not take health insurance, and we are working actively with them.
What's their reason?
They want their cash there and then immediately.
Is it that you don't pay on time?
And then they, for some reason, they have their procurement. Whenever we have negotiation meetings, they always want a higher price than any of the others. At the moment, the polyclinic has now gone on to health insurance. So,
polyclinic?
Yes. So
the main teaching hospital, no?
But the main teaching hospital, no. We're working on it.
Why are they peculiar? Why should every public hospital pharmacy be on except Kolubu?
They, I guess they are the premier hospital of Ghana, the biggest in West Africa, and they've been allowed to do whatever they want for a very long time.
But not anymore from you?
We are working on it.
Okay.
We are working on it, trust me. Yeah. We've come a long way with them, and for a long time they wouldn't even get credentialed. And then we sent their claims back one day, and they came and got credentials.
I see. So it's work in progress.
It's a work in progress.
So things will change. How long? 3 months, 6 months?
I can't tell. It depends on the other party as well. Okay. But it's a work in progress. I think there's a lot more cooperation now. And, things are
beyond Kolibu being that peculiar example, or others should take it. Pharmacies, public hospitals.
Pharmacies in public hospitals, yes.
They must. And if they don't?
If you have a valid NHIS card, they should.
Okay.
If you want to check your policy, by the way, just do *929#, choose the first option, follow the prompts, and it will tell you if you're active before you go to the facility.
Okay. Let's talk a bit about the task force that you mentioned. That task force that's supposed to do some work. What are they supposed to do again, and how will we see them operate?
Well, they are actually in the facilities now.
Are they in special uniforms?
Not at all. They're undercover.
Okay.
We have undercover agents.
Okay.
There are undercover agents in all the major hospitals trying to gather the evidence, is what I should say, so that we can really get to the root cause. You can clamp down on people, but if you don't deal with the underlying factor as to why they are behaving that way, it'll just rise up again in another area. So we need to get to the root cause of why these illegal payments are going on.
Okay. Every time there's talk of health insurance, and especially national health, the talk of cancers come up, and there are questions raised about what the scheme can take and what it cannot take. But as a general rule, does the scheme take any kind of cancer treatment at all?
Breast cancer.
Okay.
Fully. We're very proud that last year we're able to do a deal with one of the major suppliers of a cancer drug. And one of the drugs, Herceptin, was put on our medicines list. I think we're the first sub-Saharan African country to put it on our national list. Mm-hmm. And we're getting pretty good results. We're hoping to publish something around it. And what they have done is they've upgraded. At first, it was only Kolibu and Komfanochi. Cape Coast, Tamale, Ho, all 5 centers are now fully primed to deal comprehensively with breast cancer.
Oh, that's good. What about childhood cancers? They seem to be on the rise now.
Yes. I'm going to tell you. 2020, on the campaign trail, and out of the corner of my eye, I see a little girl run. So I told them to grab her. She's got a swelling, and they've put all these herbs and things on it. I looked and I thought, I've been out of the hospital for a while, but this is Burkitt's lymphoma. So now I speak to the grandmother, get her to Agogo Hospital. And it is. But it's not covered by health insurance. And so we all have to rally round and try to get her treated. 80% of those cancers are curable. In Ghana, we're only managing 30% cure rate.
Why?
Because really, financial barrier, lack of awareness. The best thing we can do is get it on the health insurance program.
Is it getting on? How soon is that?
NHIS week. Please allow me
to... I need an answer on this one. Then we'll go to the week.
No. Allow me to build up to it. So what we are doing now is we're doing the costing. Mm-hmm. So we can have the coding, the costing, the treatment protocols, even the diagnosing protocols. We want to document all that. And I must commend Prof. Renner and others, Dr. Osetutu in Komfanochi. They are really working hard with us to really put everything in place. They estimate about 2,500 children a year. And if we can save 80% of them, that is huge.
Okay.
And it's something we're working on very hard to try to do.
You still haven't answered my question. How soon is it coming online?
Watch this space.
Would it be this year?
I said watch this space.
I'm watching, but I'm asking.
No, don't steal my thunder. Don't steal my thunder.
I'm not stealing your thunder. I'm asking a very simple question. How soon will that be?
Very, very soon.
This year?
Watch this space. That's all I'm prepared to say for now.
Okay. Before we wrap up, on the NHIS week, what's it all about? What's going into it?
Well, it gives us a chance to get out into the community. Mm-hmm. We will always launch something new. It will be from the 15th to the 21st of November. So the Monday, the 15th, we'll launch something new on NHIS.
Something new?
Yeah.
But you didn't tell me.
Nope. Watch this space. And then Tuesday, Wednesday, we will be out in the community everywhere. All of us leave the office, interact with the public, educate them, try to listen to what the problems and challenges are. We'll have our registration kits out in the field so people can register, renew, whatever they need. The Thursday will probably be dedicated to private health insurance because we are the regulator, not the scheme, but the regulator. So we'll bring the various parties together to talk around that. And then we'll continue for the rest of the week, sort of public engagements the whole week. So you'll see all our staff in their T-shirts in the streets.
Right. Dr. Selby, that'll be how we end our conversation tonight. What's your own vision for what you want to make the NHI by the time you say enough, you're done?
We need to achieve UHC. To achieve that, 80%...
What is UHC, for those who don't know?
Sorry, universal health coverage. The whole world is trying to achieve it. There are three prongs to it. One, 80% of your citizens must have access or must be members of a scheme, whatever.
Currently, we are at...
Currently, we're at 52.3%.
Okay.
The second one is 90% of the diseases should be covered. We are there already, actually. The third one is out-of-pocket payment should be less than 20%.
Where are we now?
The latest World Bank figures say we are 37 or so percent people being asked to pay. That has to be eliminated. So that's what I want to achieve. It's not solely up to the NHIS, it's the whole health sector. But we believe we're the catalyst for Ghana to achieve UHC.
And are you getting the buy-in from all the related agencies to make this possible?
Oh, yes. Ghana has signed up to achieve this by the year 2030. But we'll get there before it. I believe in us.
Before 2030?
I believe we can do it.
Okay. Thank you for your time.
Grateful. Thank you, too.
Grateful. That's Dr. Lydia Selby, the Chief Executive Officer for the National Health Insurance Authority. That'll be it for us tonight on State of Affairs. I'm Francis Aban. Up next is Duvet with Miss Nancy. Good night.
Do you use your VJJ, your honeypot? I mean, that $1 million spot. As a bait, do you use it to get what you want every now and then? Does the VJJ still have value? On Thursday, we get to discuss the value of the VJJ right here on Duvet at 10 p.m. And joining me this Thursday is a fitness guru, Josh Ansah, the very sexy Yazzie of GHOne TV, and the Bishop Ishmael Otu. It's going to be an amazing conversation that you can't afford to miss. My VJJ definitely has value.